I was hoping I would get a promotion that would still say Charlie over here. Well, good morning, everyone, and it's a privilege to welcome you to sunny, for the moment, Chicago. And we're really grateful that all of you were able to make it. I know the weather has been difficult and somewhat challenging. I send you Victor and Daryl's best wishes. They are in airports as we speak, having been rerouted on a number of occasions, and they wish you a happy morning. They will be here hopefully by noon. Now, one of the things that I'm privileged to do is to sort of kick off today's festivities and discussions by trying to frame the question that we have to ask and answer. So I want to share some, these are personal reflections on the clinical learning environment and clinical identity formation, and the clinician's role in this identity formation of themselves and others. And I'm going to use physicians as examples, but I think that whenever you see physician in these slides, you should substitute your own specialty, because I don't think it's any different from nursing, pharmacy, dentistry, or other of our caregiving colleagues. We all form our identity in a similar fashion. And when we speak about the development of a clinician, we have a trajectory, a learning trajectory that is common among all disciplines. In medicine, it's timed in a peculiar fashion. And on this graphic that we prepared a number of years ago to try and describe the continuum of medical education, you see the acceleration in the development of the clinician during the graduate, or what in some countries called postgraduate medical education phase occurs. Think of the medical student who graduates and starts out as a novice in general surgery, and 5 years later enters clinical practice as an expert in general surgery. That is a dramatic, accelerated skill set development and identity formation. That path is present in all of our clinicians as they are developed. At times differently in different disciplines based on the educational sequence and how the sequence is accomplished. But there is an accelerated and critical phase in the education of the healthcare provider that forms the future of that individual. And I'm going to try and convince you of its importance. Now, we are socialized into our professions, and we develop an identity. And this work by the couple Cruz, a husband and wife physicians from Canada, is I think important for all of us to read, and I think it's germane when we start to talk about the impact of the learning environment on individuals. We develop a representation of ourselves, and it's achieved in stages over time. And the characteristics, values, and norms of the professional are internalized. We don't just act like a nurse, we become a nurse. We don't just act like a dentist, we become a dentist, and that has real meaning. It results in a way of thinking, a way of acting, and a way of feeling as an individual like that professional. Now, in medicine, the greatest influence on physician identity formation takes place during residency training. And we thought that we would use that as an example to talk about the impact of the learning environment on the individual to frame our comments this morning. And I'm going to use professionalism as one of the 6 domains of clinical competency to speak about this. So I want to tell you what our views of professionalism are. There's a difference between professionalism, which are the outward manifestations that others can see in you as you behave as a professional in your role, versus your professional identity, which is who you are as an individual, who your persona is, that set of ideals and motivation that's part of who you are, and why you do what you do that manifests itself then as professionalism to others. It's that internal motivation that is fundamentally important. This is often difficult to explain to lay audiences, but I put it this way. What would you want the motivation of the surgeon that takes your child from the emergency room to handle a traumatic injury to be? Would you want it to be idealistic and humanitarian, or would you want it to be pragmatic, utilitarian, and economic? I think the former. And that is the essence of what we're talking about here. The underlying motivation about why you do what you do and how you do it. We are much more than a collection of skill sets. We are individuals who are motivated for a particular goal. Now, how does this happen? Well, this is not unique to medicine or nursing or dentistry or pharmacy. We enter these environments with existing personality and personal characteristics. We all have our own cultural background, our own personal beliefs, our educational background, sexual orientation, and a whole series of other characteristics. And we walk into an environment, and that environment creates a negotiation. We evolve. How many of you have had the chance to observe students in your discipline as novices and then at graduation? They are not only older, they are not only more skilled, they are different people than when they entered. They think differently, they act differently, their motivation is different. It is that negotiation, that socialization that has occurred during that learning period of time, some of it accepting the norms, some of it creating compromises, and some out and out rejection of some of the things that they see or they're asked to do, that results in that evolution of the individual. Now, in medicine, we have spent most of our time thinking about the development of the overt, clinically manifest skill set that creates a clinician. We think about moving a physician from a low level of participation through graded authority and responsibility under changing supervision to create the expert who then graduates from residency and fellowship training. But what we have not concentrated on, to any great extent, pardon me, is this existing personal identity transformation in the community of practice with the written and hidden curriculum in the clinical learning environment that causes this socialization to occur. Ultimately, they emerge not only as a fully baked clinician, but a new person with different personal identities. And the nature of those changes are fundamental because they are durable. And just think about this from a well-being perspective. If we have existing personal identities, socialization happens. What do they do early on, right? We learn to play the role. You pretend until you become. It's the imposter, the syndrome that we heard so much from our young trainees in a previous session. Learning the language, learning how to deal with the ambiguity that is omnipresent in our environments when we care for patients in unusual circumstances. Learning how to deal with the hierarchy, learning how to deal with the power structure, all has an influence. And what does it do? Well, it can induce anxiety, fear, and frustration. The cognitive dissonance of people telling us what to do and then not manifesting that in their own behaviors creates tremendous internal strife. We see it manifest in some individuals that is detached concern, cynicism, the loss of innocence of the PGY1 in medicine, for instance, is almost a given. And then we used to see what we used to call black humor or inappropriate humor, no longer acceptable, but certainly a manifestation of that kind of stress. And what we hope is that it's balanced by gradually increasing clinical competence and confidence, creating satisfaction and joy, and then moving that identity formation in a positive direction. But sometimes it doesn't work. Now, you might say, well, that's fine. They leave the learning environment, they go into practice, and they'll be fine. It'll work out. Well, it doesn't actually happen that way. And while we don't have a lot of studies around this domain and its impact, other than the impressions of educators, we do have studies in a number of different domains, whether it's in clinical judgment, as evidenced on standard certification examinations, whether it's in the cost of providing care up to 20 years after graduation from residency training, or whether it's in the safety of clinical care up to 15 years after graduation, the impact of the clinical learning environment, the judgment used in the clinical learning environment, the way that patients are managed and their cost, or the safety of their clinical care rendered in the clinical learning environment is measurable, that impact up to 15 years and in some cases 20 years after graduation from residency training. So it is not a giant leap to suppose that the coping mechanisms and the other dimensions of identity formation that are caused to occur in the clinical learning environment will have a similar durable impact. And lo and behold, the factors that affect us in the clinical learning environment are exactly the same factors that were identified by this group as factors leading to burnout in clinicians in the clinical and care environment. So it is exactly that same learning environment. And I would point out that we are all lifelong learners. The clinical care environment, wherever we find ourselves, is our individual clinical learning environment for the rest of our careers. So it is fundamentally important that we understand the clinical learning environment, the impact of the clinical care environment on our identity formation, because it continues to evolve throughout our careers. And we need to especially pay attention to our trainees because we're setting them on a path based on the environments that we expose them to. So my final thoughts are that the clinical and care environment is the learning environment for all professionals at all stages of our careers. The learning environment during formative stages has an outsized and durable impact, not only on clinical judgment, cost of care, and quality of care, but also personal and professional identity formation and our well-being. And the National Academy of Medicine identified extrinsic and intrinsic factors affecting well-being and resilience of clinicians affect our ability to collectively deliver on all four aspects of the quadruple aim.